Warm welcome to everybody, our panelists and our participants who are joining us. And I'm sure we'll get a few more joining us during the course of the afternoon, because many people will know that the HousingLIN's happy hour sessions, our web platform, normally commence at 4 o'clock. But such is the excitement and the amount of information we have for you today that we've actually brought it forward by an hour. I'm really pleased that we're able to bring you this launch event in partnership with Octavia Housing and St Christopher's, and also to draw on wider learning as well. Hence why this programme is in two parts. We've got part one, which is about the Better Lives, Better Endings and Extra Care project, and delighted we've got esteemed speakers who are going to launch the project, but also share their work during their findings during the course of the programme. And then later on, after a short Q&A session with the panelists, we'll move on to our second part. And that part two, we'll be sharing that wider practice. And we're joined by Gina King from Claire Henry Associates. She's herself an independent consultant trainer. Michael Spellman, who's very well known to the HousingLIN for all the work you do on dementia and wellbeing at Extra Care Charitable Trust, but also working closely on the Cruise project. And Jamie Lyndon Lewis, again, of Housing 21, a key partner with the LIN as well, on the work you've been doing around your bereavement statements. And we'll again pull this all together in a Q&A and round table discussion before Liz gives her final thoughts and I bring the session to a close. But before I hand over to part one, I just wanted to say that it's nearly 9 years ago that the HousingLIN, working closely with the National End of Life Care Programme at the Department of Health, published its own report with the Department of Health on some aspects around end of life care. So nearly 10 years later, this is a long awaited event to really promote what's really happening around developing a good practice. And indeed, Claire Henry, who can't be with us today, and Gina's here in her place, was part of the people who commissioned that first report. So I'm not going to go on for ages because you really want to hear from the experts in the field. And I'm really delighted to hand over to Neil Mccarthy, who's Assistant Director of Care, Support and Communities at Octavia, who will tell you a little bit about Octavia and their presence in West London. He will be followed by one of their colleagues, Leanne Joy, Head of Care Quality at Octavia. Antonia, who's had a leading light in writing and co-authoring this, will talk about the report, and be followed by Liz, who's also the co-author from St Christopher's as a senior associate. So over to you, Neil. Thanks ever so.
And thank you, Jeremy. Well, good to be here this afternoon. Very excited about this project. Just thought, I'm going to do a double act with Leanne Joy, my colleague who's been working on this at Octavia. So first we'll introduce ourselves and what we do. So my name, as Jeremy said, I'm Neil McCarthy. I'm the Assistant Director for Care and Support Communities at Octavia. We're a community-minded registered housing provider with around 5,000 properties in central and west London. I lead the strategic and operational management of care support and the communities work. We've got about 450 units of supported, sheltered and extra care housing, community hub in North Kensington, and a range of support services. We mainly focus our care offer on older residents.
And I'm Leanne Joy. As Jeremy said, I'm Head of Care Quality for Octavia, and I lead on care quality, learning and innovation across our 7 extra care schemes, and we're preparing for the opening of our 8th in Harrow over the next year. So I'd like to ask Neil a question, is why is it so important to get our approach to supporting people towards the end of their life right in extra care?
Well, I suppose I wanted to just start here with the UK government strategy for end of life, which I think goes back to 2008, recognising the need to improve the experience of those at the end of life and as they approach it, and set out what might constitute a good death, which often people find a little bit of a strange concept, but it's about being treated as an individual with dignity and respect, being without pain and other symptoms, but I suppose most importantly, being in familiar surroundings and being in the company of close friends and or close family. And there's a statistic when we started this work, which feels like it was a number of years ago, pre-pandemic. There was a statistic that jumped out at me that 74% of people stated a preference to die at home. And what was seen at the time is the number of deaths in hospital was going down, but the number of deaths in care homes was going up. And we don't provide care homes, we provide extra care. And we looked in our extra care schemes, and as well as finding an increase in terms of complexity of need and working with people with a range of support needs, there was also an increase of those dying while resident instead of moving on to higher need provision. And it was sort of our wish, if you like, to provide better outcomes for those people. So we also had feedback from our staff of their experiences of supporting people as they deteriorated, as they neared end of life, and the need to be heard by professionals and deal with grief of losing someone they'd worked with for some time. We all know about there's health inequalities and inequalities around social care, particularly for older people. And this is evident, and there was a real impact on quality of life as well as quality of end of life. And we wanted to get the best outcomes, particularly for those people with increasingly complex needs, including those with dementia, people with mental health issues, and those with learning disabilities. And there was a key question for us as how effectively health and care home services and our own extra care services were changing to deliver the best experience up until and at end of life. And we looked at frameworks such as the gold standard and the 6 steps to success, though these seem geared towards a more medicalised model. And we wanted to recognise it was about assuring quality in the later stages of life and not just at the end of life, and we don't employ practicing nursing staff, whereas I think some organisations do. And we wanted a more holistic approach that could really speak to our carers in the same way the care certificate did, and develop champions to take the lead to enable change within services. So we sought to develop a philosophy and a learning programme to develop our workforce. So I wanted to just reflect back to Leanne, sort of as going through this process. What influenced the philosophy and the approach at Octavia?
Well, Atul Gawande, I'm sure several of you or most of you probably heard of, it was a surgeon, and he considered his experience of dying and questioned the medicalisation of death, as Neil said, in Western society in his book, Being Mortal. And he reminds us, and a quote from him, that health services sometimes offer a cure, sometimes only a salve, sometimes not even that. But whatever we can offer, our interventions and the risks and sacrifices that they entail are justified only if they serve the larger aims of a person's life. When we forget that, the suffering we inflict can be barbaric. When we remember it, the good we can do is breathtaking. And it was this book that inspired our search to be more creative, which led us on to the Better Lives, Better Endings. We had a book club of managers, read through that with our chief exec, and it really inspired us to do more. So we embedded advanced planning into our care and support planning documents, making it part of the discussion. And we recognised the need to empower our staff if we really wanted to bring about a culture change. For all staff to recognise that any one of them can have a key conversation with a person, and that needed to be captured and responded to in a sensitive way. That's from domestics to managers, and conversations hardly ever happen at formal times such as annual reviews. They can happen at any time, when you're having a shower, when you're cleaning, etc. And they need to be recognised and captured, as I said. We recognise that later life can bring significant change and can be lonely and an isolating experience for some. And we wanted to ensure that people were able to participate in activities and do things they want, albeit tailored to their changing needs. We wanted useful tools and understanding of key relationships and how these will work together in the interests of individuals. So if we were going to make a real difference, our staff needed a stronger voice in health and social care. They needed better knowledge and more confidence that they could advocate for people and be listened to. So Neil, can you tell us a little bit more about the partnership with St Christopher's and how the Better Lives, Better Endings project worked?
So in those early days, we did launch an end-of-life policy, I think as many CQC providers were recognised. I mean, it's a requirement to do that, but we were trying to bring that alive, and we searched for a learning provider, and we commissioned St Christopher's, who are a hospice based in South East London, who have, well, the first hospice, and they had a big education department, and they ran a very engaging half-day awareness course for our staff, which focused on role play. And for the first time, we were asking staff to think about how they spoke about death to people, and also about living, you know, in those last few days, what people wanted. It was a real eye-opener to understand what was going on with staff and their range of responses. And this helped, though there was clearly more to be done. And as a manager group, including myself, we undertook a quality end-of-life training programme with St Christopher's, which took us onto the hospice wards, took us out into the community with people approaching end of life in the community. It was a real eye-opener to see how working with the doctors and the nursing staff there, about how they approached every second minute, and it raised our awareness of how to deal with end-of-life care. And again, we learned that there was so much more to be done. We wanted to make that cultural shift within our services to a relationship-based care model, moving right away from that sort of task-based model, and truly focus on what residents want in their lives and at their death. And we went on to form a partnership, which we brought together health, social care, housing and education skills and knowledge, and then through a co-production model with residents and staff, designed the Better Lives, Better Endings project. So it really was a joint project, and as you can see, we brought people on in the advisory group from CCG, from our local CCG, from social care, London Ambulance, Skills for Care, and local hospice partners. Our partnership supported our need for intensive facilitation. We couldn't have done this on our own, so that partnership really has helped us embed this different ways of working, developing our knowledge, spotting deterioration, building more effective relationships in the respect of health and social care professionals. And the works helped shape our quality agenda and recognition that we needed a quality team to continue this work. So we had people with the right mix of expertise to really embed it within our organisation. And then the team will induct new staff alongside the care certificate. It's notable that the care certificate doesn't have a dedicated standard for end-of-life care. So we've seen this really as our add-on module, if you like, the 16th standard for the care certificate that we will now embed in all our new staff. And we really believe that we want to keep this alive across our services to deliver a truly exemplar service. So that's really sort of an introduction, and from our side as for the provider. And I'm just going to pass you over to our project facilitator now, Antonia, who will just take you through sort of her experience of running through the project. Over to you, Antonia. Thank you.
Thanks, Neil and Leanne. So I'm Antonia. I joined the project in autumn 2019 for what was originally intended as a one-year project. And I'm going to talk about how we delivered it. So the first thing I want to say is right from the start, it was really important that this be a project that was co-designed with residents and with staff. So the first thing that I did when I joined was I went to visit all the different extra care schemes, and I spoke one-to-one and in small groups with residents and with staff. I didn't have a hugely structured list of interview questions. I didn't want it to feel like a formal interview. I wanted it to be much more conversational. So it was quite informal. And very much about listening and trying to understand right from the beginning, from residents' perspective and staff perspective, what would be meaningful, what would really make a difference, what they would see as being valuable about this piece of work. And the key things that came out from those initial conversations with residents was, well, firstly, that there was an interest and appetite in discussing and planning for end of life. So some people were really enthusiastic. They could really see that this would be of value for them and their families. They really wanted it to happen. Others, understandably, were much more hesitant. Some were not keen, some were nervous, and some made it clear that this was not a topic they wanted to talk about at all. For lots of residents, the predominant issues were very much about the here and now, about current quality of life. So people talked about boredom and loneliness. They talked about the frustrations of restricted mobility and not being able to go to the shops or go to the park or go to their church or mosque without assistance. And that assistance and support to do those things being not necessarily always available when they wanted it, and sometimes quite rarely available. They talked about mental health and anxiety, and they talked about physical pain. And the other thing that came across from these conversations was the very diverse resident mix that Octavia's extra care provision has. So I spoke to people in their early 50s, I spoke to people in their late 90s. That diversity came across in terms of nationality and culture and ethnicity. Some people had dementia, some had learning disabilities, some had brain injury. As you would, I guess, imagine, there was also a very wide range of different physical health conditions that people had, and many people had multiple conditions. And also in terms of language and degree of literacy, that was also a very mixed picture as well. So what that meant for the project was, it was clear right from the outset, I think, that having a very standardized or single model or single approach, where you have a set number of questions to work through, or a set number of steps or sequence to follow in a particular order, was never going to be fit for what was needed. And it was clear that really what was going to be most valuable was much more about finding ways to support staff to develop their confidence and skills, to have conversations about end of life, to initiate these conversations, and to be able to use their own professional judgments in engaging with each resident in their unique needs in a unique way. What came across from conversations with staff was, again, similarly, very varying degrees of interest and enthusiasm for this work. So some people were really positive and could see the benefits for the residents and for each other as well. Some people much more reluctant to engage with this. There was a lot of uncertainty and a lot of fear about how to broach these topics with residents. And in particular, I think there was a lot of worry that residents would find it upsetting and distressing and would interpret any attempt to initiate this conversation as meaning that staff thought that they were going to die very soon. There was also fear about being with people who were dying. So there was a sense that the organisation was going to expect people as part of their job to spend time with and care for someone in their last days, their last hours, but not knowing how to do this, not knowing what to expect, not knowing what the dying process looked like, and therefore something that they anticipated with huge anxiety and fear, and didn't see it as something that they wanted to do without some further support and understanding about what to expect and how to go about it. There was, from some staff, there was denial that it was an issue at all. So some staff told me that, of course, if a resident were to raise this topic, of course they would be happy to talk to them and support them and think about end-of-life care. But it never came up. It wasn't something that residents ever raised. And they interpret that as meaning it wasn't a priority, it wasn't of interest or important to residents. So there was some degree of denial from some staff that this was an issue at all that really needed looking at. A lot of staff saw themselves very much as part of the wider health and care system, but there was a tremendous feeling of lack of agency within this system. The staff talked about developing relationships with residents over often a very long period of time. So often years, they would week in and week out be working with and caring for particular residents. They'd get to know them really well. They'd know their personalities, their interests, their family circumstances, who their friends were. But when it came to an urgent care situation or a crisis or someone needing end-of-life care, there was a perception that somehow all these other agencies, GPs, district nursing, the ambulance service, local hospice staff, other agencies, care agency staff that would be sent in, somehow those people were now taking over. And staff who knew that resident really well were feeling voiceless. They're feeling squashed out of the picture and feeling somehow that they lacked the power or the agency to really be an effective advocate, even though they were the ones who knew, the professionals who knew that person best. And finally, I think the other thing that really came across right from the beginning was staff's feelings of grief. because they knew these residents so well, because they've been working with them and had developed such a close relationship, when a resident was very ill, was dying or had died, staff experienced a huge sense of pain and loss. But often they felt that they were just expected to get on with it, that wasn't acknowledged within the workplace, that there was mutual support in an informal way, but there wasn't something built into the system and the structures to acknowledge those feelings and also enable them to talk to other residents. So staff talked about coming in after being off for the weekend, coming in for their shift and discovering that someone who, although they'd known was very ill, someone had died, their room had been cleared, and there was a sense that they're just expected to get on with the job. There wasn't a discussion, there wasn't a conversation about what had happened, how they died. And because that conversation never happened between staff, they weren't then able to communicate and talk to other residents as well. So they were aware that residents would be feeling fear and uncertainty and not knowing what had happened, but none of this was being processed or acknowledged. And so that came across very strongly from the beginning. So again, what this meant for the project was, it wasn't so much about developing technical skills or teaching people how to do this or how to do that. There was some degree of developing knowledge, particularly about the dying process, but a lot of it was about finding ways to develop confidence, a sense of agency, and an acknowledgement of feelings. And so that was the focus of our work. And 5 months into the project, March 2020, everything seemed to be going very well. All of a sudden, the pandemic hit. And initially, we paused our work while people dealt with the enormity and the intensity of the pressures that everyone's working through, just getting through day to day. I won't go into detail because obviously everyone has been through that and worked through that. But just to say that we had initially thought we'd pause it for a few months and be able to resume our face-to-face work. The face-to-face stuff that we were doing with residents was going really well. But then by the end of 2020, it just became clear we'd had several waves of COVID, several rounds of lockdowns and restrictions. And really sadly, we recognized that it wasn't going to be feasible to resume that face-to-face work. So we shifted all our energies to developing the 9-week online program and the suite of resources that we're launching today. And just to say a little bit about how we developed the program. So in line with the co-development approach, we sought input from staff before, during, and had reflection sessions and feedback sessions after the 9 weeks as well. We met weekly for 2-hour sessions using Zoom. And at the beginning, not all staff were confident using Zoom, both in terms of the technology, but also just in taking part in the group discussions. But it was really lovely to see that develop and flourish over time, over the period of the program. It was really important for us to develop something that felt reflective and not didactic. So it was about discussion, not instruction. We wanted to create a space where people could share experiences, share thoughts and responses and ideas, and listen and learn from each other. We tried hard to make the sessions varied so they'd stay interesting. We had speakers from the ambulance service, from a local GP practice, from the local hospice, and from end-of-life doulas. And we also asked people to complete activities in between each session. And again, very aware of different time pressures that people are under. We want to keep these very short and manageable. So if you look in the resource suite, a lot of the videos that we use, they're just 3 minutes or 5 minutes long. But we ask people to watch them and then come back and reflect and discuss them at the next session. We also wanted it to be experiential. So there are some things we did. For example, we asked people to not to submit, but to go online and look at the Coordinate My Care, my CMC urgent care record, and to complete one for themselves, not pressing that final send button, but to just ask themselves, think about the issues, the questions, so that when they were then supporting a resident to complete that, they would have a deeper insight into what it felt like to really think about those issues and think about what your own needs are, what's important to you. The other thing we did was we asked the creative facilitator who'd taken part in the early stages in some sessions with residents to come and do a session online with the staff. So guiding people using collage and artwork to explore tricky issues, sensitive issues, and find a different way of expressing yourselves. And throughout the programme, actually, that was a running theme. So thinking about the benefits of art and creativity and of music as different forms, both in terms of improving or adding to quality of life, but also as ways of exploring and expressing difficult or sensitive or painful topics as well. At the end of the programme, we asked staff to consider what changes they could make based on what they'd been thinking about and learning. Liz is going to say more about that, but the one thing I did want to say was that all the ideas that were generated from the staff themselves. So all the things that Liz is going to talk about more came from staff initiation. And lastly, the suite of resources that we're launching today tells the story of the 9-week programme. It includes the details of the resources, the templates, the tools, the videos, the case studies that we used, and a few more as well. And it was really important for us to develop something that was meaningful for busy staff who really care deeply about improving quality of life and improving end-of-life care, but who are never going to go away and search through academic journals or read enormous reports to pick out the key points that are salient for their practice. So we really wanted to develop something that was bite-sized, that was easy to use, and that most importantly, that people could relate to and could see and think about the fact that people like us can make changes that matter. And that's what we hope the resource pack, the resource suite will really help people to achieve. So now I hand over to Liz.
Antonia, thanks for that. And Liz, are you ready to go? I'm sure Antonia will come back to many of the issues you raised. I'm sure they resonate both with the panelists, but also many people watching and listening in. So Liz, over to you.
So thank you very much, Antonia and Neil and Leanne. My name is Liz Bryan, as has been mentioned. I'm a palliative care nurse and educationalist. I work as a senior associate for St Christopher's Care, and I've been working with Octavia for several years now, and I've got some slides to share. Oops, sorry, not that one. Okay. Is that okay? Can you see okay, everyone? Good.
Yeah, that's perfect.
So this has been very much a collaborative project, and we've all learned so much. Most importantly, we've learned that organisation culture doesn't change just because we want it to. We have to be persistent and we need to be creative. We also may need a little help from our friends. One of the biggest lessons learned by St Christopher's in recent years has been that we may have expertise at the hospice to contribute, but experience for people at end of life is only improved when we work collaboratively with those who have other expertise to bring to the table. Octavia recognised they needed help. We were very happy to respond, recognising the significant part extra care housing has to play in supporting people to end their days in the home where they feel most comfortable. So what does that mean for the Better Lives, Better Endings project now? It means that the work is far from over. Octavia have asked me to continue to work with their care quality team, seen here, including Leanne, to embed the learning into the day-to-day operations of care delivery. What I bring is not only my established relationship with Octavia, we trust and respect one another, which is so important, but I also bring my palliative care clinical background. We've acknowledged that this makes me significantly more valuable to them, which I think you will see as I go on. The 9-week programme delivered last summer, outlined in the suite of resources, culminated in asking the participants, based on what they had learnt, what needed to change in order to enable the best possible end-of-life experience for Octavia's residents. From the recorded comments, the quality team identified 4 areas of work to focus on, at least initially. I will very briefly touch on each of these in this presentation and say something about what we're currently working on in very practical terms. My role is to meet regularly with Leanne, Vesna and Louise to facilitate an action learning approach. In other words, they do all the work and I ask informed and hopefully helpful questions and encourage them when the going gets tough. And of course it does, frequently. We're working in the real world. There's a requirement, understandably, to be able to evidence impact and the improvements we want. But Octavia is a relatively small organisation and progress is dependent, at least for now, on a few key people. Life happens. We have pandemics, we've discovered. We experience loss ourselves and are affected by world events. We must persist, but we must also be attentive and kind to one another. And I'll say more about that later. It had become really clear during the project that care that only focuses on living now and is cautious about exploring the future is likely to miss signs that someone may be becoming less well or due to natural aging becoming more frail. This often results in something that could have been anticipated becoming a situation needing urgent care and possibly avoidable hospitalisation. One idea being mooted is trialling a traffic light system of assessment into regular review. No change or apparent issues would warrant a green. Some concerns that might just need referring to external professionals for assessment might be amber and could return to green if successfully treated. Significant physical change and confirmed irreversible life-limiting symptoms signalling end of life would be red. You get the idea. This is yet to be implemented, but we're exploring the practicalities and how to implement in conjunction with everything else. The other key initiative is the use of the Circle of Support tool. A template can be found in the suite. I won't go into detail here because you can read all about it, but this has stirred up some real enthusiasm in the quality team, and we can see real potential as a tool to support change in practice. Again, much is made in the suite of resources of the fundamental importance of good relational care. This is essential, and without it, all else will fail. We are therefore working on several initiatives to equip and enable staff to prioritise and enjoy effective relationships with residents, beginning with communication skills training from induction that recognises the importance of encouraging, where appropriate, and supporting conversations about the future. We also recognise that other creative activities can be really helpful for those who don't find it easy to communicate verbally. Focus on the Circle of Support has highlighted the importance of involving family and friends and finding natural and informal ways of doing so. For me as a health professional, the most significant learning has been around how medical we have made end-of-life care and how disempowered social care practitioners often feel. The quality team also recognised the importance of being better connected to potential partners and developing respectful and effective partnerships. To this end, we have been looking at each of the schemes and what multi-professional team meetings they already have in place and how they can develop better relationships externally. And last but by no means least, I return to the subject of being attentive and kind, not just to service users, as if their experience of life was somehow different from ours, but to one another, recognising and acknowledging our place in the community alongside residents, family members, friends, volunteers and other external colleagues. The memorial garden at Miranda House shown here is a tangible example of the product of working together to make a space to be human, a space where anyone can come to honour someone or something that has been lost, or to just feel. The quality team recognise that each of the 7 schemes may want to create their own, using their own design. It may not be outside. It might not be a physical space, but a regular and facilitated time to reflect. That's absolutely okay. Well, that's enough from me. Let's hear now from Miranda House. We have a video.
And thank you for joining us for the unveiling of the Memorial Garden, a place for people to really remember loved ones. Memorial Garden.
Here we go.
Thank you. Josie, on behalf of Miranda House, all the staff, all the residents, just want to present you with a little token for all your hard work.
Oh, that makes me cry. It is my pleasure to do all this hard work together with the staff and the tenants. This is all for them to enjoy. She knows straight away what to do.
No pressure.
Due to Josie's creativity, we can sit and enjoy. However, we are also here today to remember the dearly departed of Miranda House, to honour their memory and celebrate their lives. This moment is even more poignant as it falls in November, a special month for quiet recollection.
Thank you, Liz and colleagues. That was a great presentation, and also very poignant to watch that as a living record of both Miranda House, but also of the project. So thanks for sharing that. One thing is, could one of you just say where people can access the resource suite? Because I think we've talked about it. I know the LIN has got it on the website, but I'm sure it's also available on St Christopher's and Octavia's. Is that right?
That's correct, yes. And I think we're just going to finish, each of us, we're just going to say one thing that we've learned from being involved in the project before we break. Is that right? Shall we start, Neil? Would you like to go?
Yeah, I mean, for me, it was really that it's that ongoing journey that, you know, to really change the culture. But we're dealing with individuals and they're always changing. And that we want to continue to seek to embed this using our quality team to ensure it's sustained within our exemplar services.
Thank you. Leanne?
It's just, that the circle support is not just about people, it's about things that people do and they love to do, like walking in the countryside or visiting a pub, or, these things matter, and they matter more when you can't do them without support. And it's the recognition that the end of life for our residents is more than just the last few weeks or months. It's an ongoing journey, and we need to support them through that with our support.
Thank you. Antonia?
For me, it was about the value of an approach and developing resources that resonate emotionally with staff. That emotional connection was really the way into helping, enabling staff to feel more confident and to connect with these issues and to really bring about the kind of cultural change that makes the biggest difference.
Lovely, thank you. And final thought from me, extra care staff don't need training, they need empowering. That requires a very different approach, one that recognises their experience, their knowledge of the tenants and their ideal position to work in partnership with other agencies. Thank you very much.
Liz, thank you, and that's been a really poignant sort of presentation, suite of presentations. And in terms of the summing up, we're also joined by a few other people. I'm just wondering whether any of you wanted to contribute any thoughts from either your participation through the process or what you've heard this afternoon. So particularly Louise from Skills for Care, or Karina from London Ambulance, as well as Maker from is it Van der Veeg as well, who's got a specialism in palliative care. So either any of you want to just sort of have a few words?
Yeah, absolutely, by all means. I think empowerment is exactly the right word, Liz, and that was great to hear that. And coming from a workforce body, I think it's important that we empower the workforce to support people at end of life. But what I really liked about this project is that we also looked at and understood the effect death and bereavement has on staff. And that is so very often missed, and it can affect staff very deeply when people they've supported for a very long time do die. So it's great to see that as part of this project as well.
Maika or Karina?
I'm happy to go first, Karina, if that's okay. Just really, really impressed with the suite of resources that have been produced, but especially at St Christopher's Care, we're excited about the opportunities that this can offer to the sector. There's a great opportunity for partnership working and a real opportunity to transform learning in the sector. It's so nice to hear about experiential learning, about transformational learning, and that's absolutely what's key and what's required if we want this to be effective and to have an impact on the staff, but also service users, clients, the people we care for. Thank you.
And I think I reflecting on what everyone said here, I think it's been a fantastic programme. I think my kind of key takeaway from the session we did and speaking to all of the staff was that real relationship that people build up with their residents. And I think sometimes as ambulance staff, we perhaps don't appreciate when someone is towards the end of life and they're unwell, that these people are like family to them. So something we're incorporating into our education is how to support not only family members but care staff around that patient that's dying.
Well, thank you. I think that sort of echoes a point perhaps that Antonia also made about the continuity of care and support, and that sort of holistic approach, especially where in some situations people's experiences are taken out of context or not known about. So that sort of life planning is really important. I'm conscious that we've had if I can dare say it, an absence of questions. There was one question earlier about the Gold Life Standard, I think, which I think we'll come back to later. We're running slightly ahead of schedule. I was just wondering whether we could take the opportunity to move to part two and introduce Gina, Michael and Jamie, because I think they're also going to reflect on both what we've already heard, but also draw attention to other practices and other situations. And I know both from Michael and Jamie a lot more perhaps on the bereavement side of that, which is obviously the lessons learned from end-of-life care within a variety of specialist retirement and extra care housing settings. So if it's okay with everybody, I'm going to ask Gina, who's an independent consultant and trainer, who's had a very quick look at this resource suite. And it'd be really good both to take your take, but also some of the practical lessons of your own experience about that workforce development, and really understanding that I think co-production and collaborative working came through right throughout. And I'm sure you'll touch on some of that too. So Gina, over to you.
Thank you. I'm just setting myself up. Okay. Right, thank you for including me today at this special event. I was very excited when I saw the suite of resources, and I've looked at it in depth and see where I could put the wider practice with the suite of resources. So as you can see, I'm part of Claire Henry Associates. But I'm
Gina,
also
your slides aren't appearing on my screen. I don't know whether you can just share your screen.
No, I'm not seeing them either. Would you like me to take over the sharing of your slides?
Yes, please.
Great. So I'll do that. Just give me
I thought it was weird because I'd lost you all, and then.
So that should
okay, so I'll just give you a nod then, Jerome.
Yeah, if you just say next when you want me to move to the next slide.
Perfect. If you can just click, then you'll see the Claire Henry Associates pop up. Lovely. Okay, as I was saying, I work with Claire Henry. I'm part of her associates colleagues, but I'm also an independent consultant and trainer. I've been working in end-of-life care for a very long time. So this year's 37 years since I've been a nurse, but I've been working in specialist palliative care and strategically leading on end-of-life care. So I know Claire Henry, who Jeremy mentioned earlier, for many, many years, and worked with her on the National End-of-Life Care Programme and worked within Gold Standards Framework and so forth. So what I'd like to do today is share a presentation with you which captures how the suite of resources fits into the context of today and what else is happening nationally. So can you click on, please? Thank you. So here, just a very simple slide, but just to put across about the ambitions for palliative and end-of-life care, which was released in 2015. Now, the strategy, end-of-life strategy, which came out in 2008, this was 7 years later. But what happened within those 7 years was the more care, less pathway, which was looked into the Liverpool care pathway. And then following that, one chance to get it right in 2014. And then there was the choice review in 2015. So the ambitions, following NICE guidance, was released in 2015 and was a framework, a national framework for local implementation until 2020. The latest version is 2021 to 2026. But what I want to demonstrate here to you is looking at the 6 ambitions, which really is where the suite of resources demonstrates. So we've got, as you said, the person-centered care. We've got each person is seen as an individual, that fair access to care, the maximising comfort and well-being, the coordination of care, the staff being prepared to care. And as highlighted before, it's not having to do training, it's that empowerment. So it's that prepared to care and supporting them, which the suite of resources helps with. And then the last one, which was added in as prompted by Dr. Julian Abel around compassionate communities. And that's each community is prepared to help. So it's moving away, as we've been highlighted before, about that medicalised model into about that more, let's look at that person in the community. So I've just done a very simple arrow here just to demonstrate your themes that were in the suite of resources. So all staff prepared to care. So theme 1, recognising the need for cultural change. So it's supporting those nurses, not nurses, the staff, in actually, their own development and looking at the care certificate that supports them to do that. Can you just do the next slide, please? Oh, thank you. So that was meant to slide in, but this what I wanted to demonstrate that the 6 ambitions that I've talked about, but really the most poignant bit of it is this statement: I can make the last stage of my life as good as possible because everyone works together confidently, honestly, and consistently to help me and the people who are important to me, including my carers, which this just sits snugly in. Next slide, please. So here I've just delved down a little bit further within the ambitions and look at the foundations. Now, sometimes the foundations get lost in the ambitions because I think because they're not so colourful, but these are the building blocks of the ambitions. And here we have 8 foundations: personalised care planning, shared records, evidence and information, those important to the dying person, education and training, 24/7 access, co-design, where we just heard that today, you know, that co-production, and that leadership, you know, but leaders leading the way forward together in partnership, which this is demonstrated by the development of this suite of resources. But what I did, because I'm quite a sort of detailed person, I actually mapped the care certificate standards against the ambitions and the foundations. And that's what I will be talking about in the next few slides, just to highlight where we are nationally within the ambitions and where the suite of resources fit in. But I just wanted to demonstrate to you how they cross over. The care certificates cross over with the foundations and the 6 ambitions. Next slide, please. Okay, can you click, please? Thank you. So here I've just pulled out not all the ambitions because we haven't had all day and we need to, you know, focus on the key points here. But each person is seen as an individual, the ambition, and personalised care planning that sits underneath that. So what's happening nationally is there's new personalised care guidance in the palliative and end-of-life care context. And they've looked at the principles to support commissioners, providers, key stakeholders, because although I used to be working in personalisation with the national team, because I was a previous regional lead, that actually the principles sometimes got lost. So what they're doing, they're applying the principles to end of life. And this new guide will be available at the end of March. I have hyperlinked on the PowerPoint to make it easier for people to access more information. But there is a slide at the end for further information if people would like to explore and how to access these new guides that are coming up. The next one is having these universal principles for advanced care planning, which is due out mid-March. But this is really just to, there's lots of information around advanced care planning. It gets lost. There's lots of different language. What do we mean by advanced statement? What do we mean by advanced decision? What's a lasting power of attorney? You know, how do they fit in with what we mean by advanced care planning, which we mean actually planning ahead, you know, working together to support our wishes and preferences for future. So the national team are pulling together the principles, which will be released soon. And I think that would be really helpful to have the consistency of language across all our work domains. There's a new public-facing website called Planning Ahead, which Catherine Mannix has been supporting, that's available if you would like to look at how to support your residents or support people you work with about thinking a bit wider about planning ahead. And then there's the Advanced Care Plan, which is a website for England and Wales to actually, that's got a suite of resources as well, if people want to start documenting what they would like to do in the future, and if they lose capacity or they're not able to communicate themselves. And then there's been a recent report on the study of the use of do not attempt cardiopulmonary resuscitations that was carried out from March last year to March 2020 to January 21, to actually look at how was DNA CPR being the decisions being held and carried through and having those conversations. And what it demonstrated in this report, that actually across these 23 trusts, that actually there was an increase and there was less evidence of having the conversation, which moves me swiftly on to respect. The Recommendatory Summary Plan for Emergency Care and Treatment, which is a two-sided form that has been developed to support conversations around planning ahead, but more solely on what you would more the comfort measures versus active treatment. And it's enabling that conversation between the professional and that person, and for emergency services or other professionals that are not used to that person, to give them a quick review of this person and what the person would like or not like to happen. So it's kind of like more of an advanced statement. But what I want to highlight here, that actually the form may not be legal, but the conversation is. And these conversations are really important, and actually enabling staff to feel empowered to have these conversations based on that relationship. This is where the respect form fits in. Next slide, please. Okay. And can you click again, please, Jerome? Thank you. So just to continue on this theme, because I feel it's one of the most important ones, the ambitions, is to highlight what else is happening around the UK. So No Barriers Here is mentioned in the suite of resources, but this is another community-based project about enabling using arts and crafts to enable conversations for those that maybe have difficulties in being engaged, maybe due to culture, ethnicity, there might be learning disabilities. And, it's been a real useful project since St. Mary Stephen's Hospice, that have carried that forward. And at the bottom, you can see at the slide, the national team are promoting the early project that's been piloted in certain sites across the UK, but more England. And you can see there's a website here that helps individuals, professionals, if they want to look at identification, if they want to look at personalised care and support planning and sharing information. So it's a quite nice, simple website to support professionals or maybe individuals around early identification and personalised care planning. Now, I've snuck in the ACT tool, which is something I developed back when I was a regional lead. And it's a handy little tool that actually is a wheel that bases on 6 disease spectrums. But what I want to highlight here, because is the most important thing of ACT, and that's around acknowledge, communicate, think ahead. And I've learned in all my experience of being a nurse, a strategic lead, developing tools and resources, the best way to get information across is keeping it simple and straightforward. So I developed this tool, not just for identification, but to support professionals about having that conversation. So Professor Biwi has kindly given me permission to pick it back up independently and take it forward as a project for myself. So I thought it'd be nice to share it today, that how we can all work together with all our different creations and innovations. Next slide, please. And can you click, please, Jerome? Thank you. So care is coordinated and shared records. So EPACS, Electronic Palliative Care Coordination System. So you mentioned my Coordinate My Care earlier. That's known as an EPACS. And Professor Julia Riley has been leading that for a long time and has done great work. And this report is just to give you examples of the drivers and challenges in the patient data sharing, just for more information. And I put MIG there because whenever you mention EPACS, a MIG comes into the conversation. So I thought I'd add that as an icon. Then just to highlight, there's grants available for 24/7 single point of access. More information is on the slide at the end if you would like to contact the national team. And then just to highlight the integrated care systems, and that actually will hopefully support end-of-life care delivery and coordination. And that the statutory arrangements will be on the 1st of July and then of the integrated care boards. Next slide, please. Okay. And click again, Jerome, thank you. Lovely. So all staff prepared to care, education training. Just link those two together. This is what we're here today, isn't it? That suite of resources. Education training is just not about actually doing a presentation, you know, providing training. Education training sits in where information is, and people can pick that up when they need to. But there's a real national focus on training around the workforce. They're looking at scoping, benchmarking and modelling. And then St Christopher's themselves here with the Lantern model, led by Heather Richardson and Marie Cooper, about looking at the contemporary model of nursing for people at end of life, and more information again at the end of this presentation. I've put in here about there's webinars available every month on different subjects around end of life. If people would like that, everyone's free, able to join. And it varies from acute trust, from going from good to outstanding, to actually looking at EPACs. And at the bottom, we've got the e-learning to enhance education and training for the end of life care. So this has been going on for many, many years, but this is still a free resource available to do e-learning. And the last count, it was 155 modules, but you can always tell me off if I got that number wrong. Next slide, please. So here, this is where I feel the suite of resources sells itself, with each community is prepared to help. And that is also those important to the dying person. The national team is looking at the work with social prescribing and compassionate communities. And you can see I've put different images here to highlight where each community is prepared to help is shining at the moment. So we have Dying Matters, if you've not heard of, that's led by Hospice UK. This year it's from the 2nd to the 6th of May. So look out, there's information again at the end. And then you've got little local areas that are looking at Dying Matters themselves. So in Leicester, Leicestershire and Rutland. And then we've got bereavement health points. Now, when I did a Google search, they were actually popping up everywhere. So we've got some in Chippenham, somewhere in Wiltshire, St Giles Hospice. So there might be one in your local area. And I believe St Christopher's is involved with that as well. And then we have the King's Fund report. And I put that in because actually they're looking at the effect of social prescribing into primary care networks and how effective it is. And is that a measurement of change? And I think since 2019, since it was started in primary care networks, I think the jury's still out for the count. Lastly, but not least, is Compassionate Communities UK. Now, there's not enough time today to go into detail, but Compassionate Communities is key, I think, to how we need to move forward to reduce that medical model. And in Frome, in Somerset, they have their own Compassionate Communities and they have won awards for the amount they've done in that area. But they've just released their exciting new website for end-of-life care and bereavement support, where I've put is bereavement around those important to the dying person. Next slide, please. So we're coming on to the end now. And just to put in what I captured from this suite of resources, what made me excited when I saw it. And that was the circle of support around actually isn't just about the individual, it's everyone around that individual. And that could be, you know, that could be the just going down the road and someone getting a newspaper, having that contact. It's about that support, that connection. And this is where I see that this work has previously done around this in compassionate communities. And this is where I think the suite of resources could be cross-referenced and support in this area, not primarily, but obviously in other areas as well. So the next slide, Jerome. Thank you. So these are all the further information if you would like to go more in depth about it, and this will be available later. Next slide, please. And I just want to say thank you. Thank you for inviting me today, giving me the opportunity to present and to be part of this exciting launch. And just say, this is no dress rehearsal, this is our life. And we just got to live it and enjoy it. So there's my contact details, and I'm just, my new website is just ready to be launched any day soon. Thank you.
Gina, thank you. And perhaps no dress rehearsals, this is our life should be on your website as well. I thought you're absolutely right. But you've also eloquently described both some really practical examples, shared some of those steps and those pathways, but also made it very relevant for this new suite, how it fits in really both with the national policy agenda, but also with things like dying matters and other aspects coming through. So really, really great links and segues there. I'm going to move on to Michael Spellman, if I can see him. There he is on my screen. Michael, welcome. And I think you're going to share your slides as well. So Michael, you're going to talk a bit about the Bereavement Support Project. And I know that you and the Trust have done a lot of work over the years in relation to this. So without further ado, over to you.
Thank you for having me. See, yes, we started this project really actually in about late 2015, working on getting the funding for quite a big project that we wanted to partner up with Crew's Bereavement Care. We were very lucky to get the funding through the Big Lottery Community Fund. The project lasted from January 2017 and finished in December 2021. I'm going to talk you through the different things that we worked on and achieved through that time. But even though the project's formally out of its funding period now, we're still dedicated to delivering exactly what we set out to do from the start, really. If you flick over to the next slide for me, that would be great. Everything that I'm going to talk about is also covered in the evaluation report from the project. So this was completed by researchers at Aston University and the University of Bristol over the 5 years. There is a 107-page version of this document, but this is one that I think is available on the Crew's website and should also be available after this session. It's a nice, more visual way of getting that overview of what happened in the project, the things that were a success, and also the things, some of the pitfalls, some of the things that we'll be working on going forward really with this. And to the next slide, thank you. It was quite a difficult project to actually evaluate. When we started off, the researchers really looked at using a questionnaire to capture the feedback from people who we'd supported with a new bereavement service. And we quickly found out in the first 6 months that really wasn't going to be the best way to capture everything that was going on in the project. There were so many different elements to the project, and also a really, really sensitive topic to actually investigate in the first place. So that whole project is really based on lots of different data strands. So it is definitely an interesting read. So take a look at that if you do get a chance to. And so to the next slide, please. This was our starting point really before 2017, when we were just kind of developing an idea for the project. What was quite often happening was bereavement and grief was really being roped in with, people need specialist support. People need to go straight to a counsellor, or someone needs to go straight to somewhere like Crew's Bereavement Care when they've had a bereavement. And there were so many opportunities really being missed. And grief and bereavement probably not really being understood in the right way, that actually can be quite a healthy and adaptive process that we do go through. Grief is pain with a purpose, and it's not necessarily something that always needs a specialist service. So what else can we be doing other than just referring our residents to external services? So if you click on for me, we started to build our three-part model. We did need some kind of specialist signposting. There were going to be both residents and staff who'd been so strongly affected by a bereavement, that they would need something like structured counselling, or particularly where a bereavement was particularly traumatic, the nature under which a person died. But actually what we really wanted to focus on was this part in the middle. What else can we be offering for residents? And our staff are always the best people to be offering that support. We have about 4,500 residents with some really vast life experiences and some really fascinating careers behind them. And actually, some of them are still in their careers at the moment. We wanted to develop a new volunteer role in extra care. And that was what we set out really early to do in the project, the bereavement support volunteers. We recruited residents into that role, provided them with training from Crew's Bereavement Care and the support from Extra Care, really so that they could be our kind of first point of call for residents who needed to talk about grief and loss. The idea was that actually staff would formally refer to a volunteer, but more often than not, and what happened in the first village we launched the project at, was that residents just naturally found the bereavement supporters. We didn't really see many formal referrals. People were bumping into the volunteers in the lift or corridor and just recognising that they were someone who they could talk to and get a bit of more support from. And if you click on For Me again, then this was that's fine, that one. That was the third part, the biggest area. And again, a lot of this was happening already without us really knowing. But people were just talking to each other. People were being neighbourly. And sometimes residents would tell us things like, actually, I'd love to speak to my neighbour a little bit more because I know they've just lost their husband, but I do shut the door when I see them coming down the corridor because I don't know what to say. I'm going to say the wrong thing. I'm going to put my foot in my mouth and things like that. I thought, well, actually, how can we help people just get a little bit more confident to have those everyday conversations with each other? So those were our three parts: signposting specialist services, having that really good bereavement support volunteer role, so residents helping out other residents, and then just generally putting out more information and resources to residents and staff around this is what you can do generally to help yourself when you've experienced a bereavement, ways of understanding bereavement, and also how to help someone else if they've been struggling with a bereavement. And to the next slide, thank you. So the bereavement support volunteers, we actually recruited 49 over the 5 years of the project. They were from quite mixed backgrounds. About a third of them had quite a professional background in some kind of helping service, whether that had been they'd been a counsellor in the past, they might have been a nurse, or worked in a setting where they were coming across people and having to offer some kind of formal help. Most of the volunteers, though, were residents who just were interested in the topic. They'd lost people themselves and they wanted to share the benefits of their experience, or they just had a really good listening ear. They understood that person didn't need to find the answers for the person. They didn't need to find a solution. They just needed to be there to listen. And we're going to continue to have that volunteer role in extra care. For many residents as well, it offered them a slightly different volunteer role to the other roles that we have. We do rely on volunteers. We have about 2,200 volunteers in extra care. And actually, if many volunteer roles might not fit for residents with certain skills, but this really did seem to attract a specific type of volunteer. Those extra 18 residents, it says there on the slide, who we trained as part of our community model, when the pandemic hit and we weren't able to go out to locations and launch the project the way we'd been doing it up to the pandemic, we thought we'd try a slightly different model. And particularly it might work where we had schemes and villages where we weren't getting any residents putting themselves forward to be a volunteer. With that community model, rather than having a specific volunteer, what we asked residents to do is just come to the village hall for a morning, have the similar kind of training and information that the bereavement support volunteers would get, but just give them that information and then just let them loose in the community, really. And rather than them actually seeking out people who were grieving or people seeking them out, again, those natural conversations, people bumping into each other in the restaurant, the cafe bar, the gym, in the lifts, people were just, I suppose what we were trying to create was a kind of like a bereavement friendly community that actually you're just going to happen to come across someone in your scheme or in your village who just gets it. Actually, the person's going to avoid asking you certain questions. They're going to avoid jumping to trying to make it better. They're just going to listen to you. and just understand a little bit more closely what it might be that you're actually going through. And to the next slide, please. Oh, yeah, so this is some of our bereavement support volunteers. So this was taken at about late 2018. So we'd already started to get, this is probably over 2 or 3 different villages in Birmingham, a really nice group of volunteers. Many of these residents were also on the project's reference group. So actually, in this photograph, as well as Eve Wilson, our project lead from Cruse Bereavement Care, and myself and Eve and a group of residents in the reference group, we just listened to them really. They gave us some great leads on what do you think we should be doing with this project. Every time Eve and I wrote something or designed a new leaflet, we'd take it to the reference group and they'd give us some brilliant advice. And yeah, within there were some really remarkable people with some fantastic experiences. And many of the volunteers are actually still active now in the locations, helping residents on a regular basis, coming to terms with various different losses. Some of the pictures you'll see in the background where we have a tree pattern with the leaves. Actually, the leaves on the tree are actually some of these residents' fingerprints. We were coming up for a logo with the project, and there's actually some of the residents' fingerprints on there. And to the next slide, please. So, yes, creating that bereavement-friendly community. In a fashion, we were quite surprised how many people actually stepped forward to either get bereavement support or be involved in the project in some way. We've been told on a semi-regular basis that people don't really want to talk about death or dying, and they don't want to talk around bereavement. Whereas actually, I think the statistics around how many people actually came forward for support or came forward to be involved was a lot. 975 residents or their family members actually directly accessed bereavement support from one of the volunteers, and probably a handful also from Cruse Bereavement Care, going on to have formal structured bereavement counselling. So there's a lot of people, particularly as well with family members. If a resident had died and family members were then coming in to do things like clear out an apartment, actually those family members also really needed something. What we were finding was that people automatically haven't always got somewhere to go or know where to go and get help. And then in total, over the 5 years, 1,460 residents actually engaged with project activities. But that might not necessarily have been them going to see a bereavement support volunteer, but it might have been them coming to a more informal information session. So those would have been sessions that Eve and I would have run in our schemes and villages. They probably last for about half an hour to 40 minutes. And we talk about grief and bereavement in a very informal way. We talk about some of the different models that are out there, the different ways that we can understand grief, the things we can do for ourselves to self-care, and the things that we can do to help other people. And the next slide, please. And staff as well. The staff training and the education that we did with staff was again a really big part of the project. The training was very, very popular. It was about 390 residents actually go on a formal course with Cruse Bereavement Care. So that was normally a day or a half day looking at things like, again, bereavement models, similar to what the resident volunteers had experienced. And around 210 staff instead opted for that more informal approach, where it was myself and Eve for about half hour, 40 minutes, just talking through this is a way of understanding grief and loss. Again, I think generally the way we train staff in health and social care, we train them to be very solution focused and to fix things. And that was where a lot of the staff were struggling. But actually, how do I help someone? Because they just want to fix the problem, and actually grief can't be fixed. The person or the thing that the person's grieving for is gone, and it's not going to be coming back. That's not going to change. And many staff were struggling with that. And actually, sometimes it felt like, so all I have to do is just listen. It's like, yeah, all you have to do is maybe give that person 5 minutes of your time and just listen to how things are for them. You don't have to find a solution. You don't have to try and worry about thinking of the right words. Just need to give that person some time and give their grief an outlet. If that person each day or each week over the next few months or years even just gets those opportunities to have that outlet about how they're feeling, might be on an anniversary or a day that's particularly difficult for them, that's one of the biggest things that you can do to give to that resident or a colleague. And that was a bit of an eye-opener for many of the staff. And the comment there made by Jenny, we've been able to open up conversations with residents, was particularly important as well for the next slide, if we can move on to that. So in 2018, Extra Care introduced the gold standard framework into the retirement communities. Started off in a very small way. One of our schemes in Kettering, Sunday Court, we're working with the gold standards framework to improve end-of-life care in their scheme. And there was just some really beautiful examples coming out from the scheme about people reaching end of life and being able to die at home in just a very, very dignified and well-planned way. The gold standard framework did actually go on to develop a set of standards specifically around retirement communities, because obviously normally traditionally it would be used in a different setting to that. Since 2018, actually 19 of our retirement communities have now become accredited with the gold standards framework, and that being their primary way of offering end-of-life care in the village. And then the remaining 2 locations are currently undergoing training. They can start putting their portfolio together and eventually going on to be accredited to be able to deliver the gold standards framework. Just want to say flick on 3 or 4 times for me. I think some of the, just one more. There we go. We've talked about this a lot already throughout the session, which has been really good. I suppose just the importance really of planning for end of life, and like on that last slide with the staff, we often got told, well, residents don't want to talk about death and dying. Actually, it turned out they really did. Residents were quite happy to talk about death and dying. I think, even I quite early on started to wonder, is it the staff who feel really uncomfortable talking about death and dying? And that's why we're not really seeing these conversations happening with the residents. And actually, residents were quite often talking about it between each other, sometimes really flippantly, actually. And so advanced decisions were really, really important to start thinking, well, how early can we start having those conversations with people? And now our wellbeing advisors in particular have done an awful lot of work around looking for those windows of opportunity to just talk to people, well, what would you like in future? It's okay for us to put these things down now. They might not be used for a very long time, but it's a conversation we can have. It's a conversation we don't need to be scared to have. Because the more we know, the more we can support that person to actually have a good death. And again, we heard it earlier in the session, and it's such a good way of looking at things, that death doesn't have to be this very dark subject. It is possible to have a good death if it's thought about early on. Well, what do you want it to look like, and what kind of control can you actually have over such a situation? Enabling residents to die in their own home was a particularly important part of introducing the gold standards framework, and just that really well-planned death that happens with dignity. Even for me, when I first started to look at the gold standards framework, when it first got introduced to Extra Care, I don't come from a medical background, and so I'd always kind of in a fashion switched off from end-of-life care, thinking that, well, actually it's something I can't really do anything about. I don't know much about it, and actually what can I possibly do? But getting to understand what the gold standards framework was all about, even for me, it started to make me think, so that's something that is possible. Me and my team can play a role in it, whether it's looking at advanced decisions, helping residents to talk about what they want for the future. It's not just about that very physical process of dying, it's about everything that goes around it as well, including bereavement. And I think from what we've been looking at earlier, many of us have all been saying the same things, but actually talking about these things much earlier on and planning for them is a really, really good thing to do. And the next slide, please. So a few other things that came up during the project that we weren't expecting, like everyone's mentioned as well earlier, COVID-19 pandemic, completely unexpected and could have thrown the whole project off completely. This project was really about getting people in the same room and having lots of interaction with people, and people getting very, very close. And then all of a sudden we were in a position where pretty much all residents were isolating in their apartments. How are we going to collect data, and how are the bereavement supporters actually going to offer people support? But actually what could have been what was a very difficult time, didn't switch off the project completely. We actually did a bit of a sideline project where our researchers came up with another methodology where they asked our residents who'd been bereaved and our residents who were working as bereavement support volunteers to keep diaries and then submit those diaries to the researchers on a regular basis so they can start to theme the findings. If you move on to the next slide for me, this was one of the themes that came out, just actually how vital the peer-to-peer support was from the volunteers, contacting residents in their apartment by phone and still doing the work with them that they would have been doing face-to-face. And lots of other themes, I think about 5 or 6 themes came out of those diaries in total. Really important stuff, even stuff about the design of the actual building, so how important balconies became all of a sudden. Residents didn't necessarily always think twice about having a balcony, but for many people, being able to go and stand on their balcony and watch a funeral procession come to the village and then leave and just feel like they had a little bit of connection to either a neighbour that they've lost at a time when many of us just weren't able to attend funerals. And not being able to have that goodbye, not being able to have that ritual after we'd lost a person really did affect people's grieving process in quite a profound way. And I think even now we're probably still seeing the impact of, you know, those more complicated bereavements people had by not being able to attend things like funerals. And then the next slide. This was another document that we put together quite early on in the project, actually. This was 2018 or early 2019. Carer stories lost along the journey. Not really possible for me to get involved in a project without bringing dementia into it. And that's kind of what happened here. We really wanted to look at, well, what can happen when we bring the topics of bereavement and dementia side by side. What we did with this document was we got together a group of carers whose partner had lived with dementia. The partner had either died, relocated into a care home, or they were still living in the village with the person. And we asked them just very honestly, tell us, what is it like to be a carer of someone living with dementia? And there was a great number of losses that the residents talked through. If you just skip to the next slide for me. This is the inside of that document, losses along the journey. All sorts of losses, you know, quite practical things like not being able to leave the house as quickly as the person used to. Someone's partner turning around and calling them by their ex-wife's name. Lots of different, quite painful experiences that really residents really heavily associated with grief. And again, there's a reason why we put this document together was not just for other residents or the carers to read it, but for staff to more fully understand the losses that a carer might experience when their partner lives with dementia. One of our residents told us that when her husband passed away, he'd been living with Alzheimer's for quite some time, and she felt a sense of relief. She missed him and she was upset and she had been grieving for a long time. But at that point, after he'd passed away, everyone came to see her to tell her how sorry that they were. And actually what she kept telling them was, I needed to hear that 4 years ago when he couldn't drive anymore. And when he forgot who I was, that was when I really felt like I was losing him. So there were some really very honest accounts in there. And even the way the document was designed, we didn't want to put photographs in there. We didn't want it to look overly corporate. We wanted it to look a bit like someone's diary, really, something that felt a lot more personal. That if you were a carer picking it up and reading it, it felt like it had been written from one carer to you and that it would be very relatable. And the next slide, please. Just one final piece of work that we did around dementia was just understanding some of the losses that a person with dementia feels, how a person with dementia might experience the actual loss of a person, what other losses might the person experience. We used a really great website, and maybe some of you have come across it before, Dementia Diaries, where people who are living with dementia can call up, leave things like voicemail or send in messages to really talk about, this is my experience of living with dementia. To do this part of the project, we got our own residents living with dementia, took many of the recordings from that website that were around death, dying and loss. We listened to those and just tried to capture them in one place to look at, well, what kind of losses can a person living with dementia experience? If we go on to the next slide, It's just a couple really, and there was one quite poignant one on here around the person becoming a non-driver, that actually their Alzheimer's diagnosis had then meant that they'd lost so much in terms of practically just being able to leave the location and do what they wanted, some of the emotional and social attachments they had to their car and their life as a driver versus now becoming a non-driver. And again, it was just that other way of looking at bereavement and loss, that sometimes it's not always a person or a pet or something that we lose, but what are the other losses that we can actually experience as we age, and start to really think about loss in that wider sense. And the next slide, please. That's kind of our project in a nutshell. So thank you very much for listening. Again, there's a lot more detail in the executive summary of the report itself. So, please do go and read that, and really happy for people to use those resources that we developed as part of the project. Hopefully they will be useful things for you. And we always intended them to be used, not just in extra care, but by as many people as possible, really. So thank you for listening.
Well, Michael, and thank you for sharing all the great work that you and the team have been doing. I know Shirley's been putting stuff in the chat, answering a question or two also in the Q&A box. So echoing some of the work you've been describing around the GSF. I think that for many people working in housing, there's probably a whole new set of acronyms here, GSF, MIG and things, so it's been helpful that we've been able to spell those out, and thanks everybody who's answered those questions in the chat. But look, I'm conscious we've got about half an hour or so before we draw to a close, and we've got one final speaker. Jamie, last but not least, again, Jamie Lyndon Lewis, working very closely within Housing 21 around bereavement care and support, and you're going to be describing the work around your bereavement commitment. So thanks very much for your patience, and we're really looking forward to hearing what you have to say.
Thank you, Jeremy. Just want to say a big thank you to my colleagues who've done their presentations. It's been really, really interesting, so thank you. Next slide, please. So it's estimated that nearly 150,000 people die in the world every year pre-pandemic. So why does it remain such a difficult topic for most people to talk about, even in a sector where we are used to dealing with bereavement and death? Next slide, please. I'm Jamie Lyndon Lewis. I'm the Head of Quality Assurance and Commissioning at Housing 21, and I want to share with you today our bereavement commitments for both employees and our residents, and the work we've done to create a culture where death is no longer viewed as taboo, and where people feel open to talk about their experiences of death. Next slide, please. But first, I'd like to take you all the way back to 2020. Whilst we'd always provided good quality care to residents at the end of their lives, the pandemic was unique in that our employees were supporting residents at the end of their lives in often very trying circumstances, was coping with personal loss, the loss of family, friends, and sometimes work colleagues. We recognise the huge impact that grief has on our residents and employees, and we felt compelled to create an environment where the aftercare provided to residents and our employees is seen as just as important as the physical hands-on care and support that we give to people. So therefore, we created a set of 6 bereavement commitments that really set out our stall regarding what people should expect from us when they experience grief and bereavement, whether that be if you're an employee at Housing 21 or a resident. I won't go through the ball, but for me, the thing I am certainly most proud of is creating the environment where people feel supported to speak about their experiences of death and the impact this has had on them emotionally and mentally. Of course, it stands to reason that when our employees feel supported during a bereavement, this flows through to the delivery of really good and empathetic care for our residents and their friends and families at the end of their lives. Next slide, please. So we brought about the commitments in a number of ways. We firstly released 3 sets of operational guidance documents, and those are around how to deal with the death of a resident, how to manage the death of a colleague, and in general, how to support employees who are bereaved. Naturally, we already had procedures in place for when a resident passes away or when an employee passes away. But we recognise that although we provided the practical advice around how to manage these situations, we didn't necessarily provide the guidance on how to support people emotionally or how to recognise and celebrate the life of a resident who's passed away. Instead, we wanted to focus on some of the more difficult areas, such as how to break the news in a sensitive way, how to support employees who could care for somebody at the end of their lives, and yet were expected to carry on at work and care for more people. We recognised that managers needed the guidance of how to support that person with emotionally and empathetically. Also, as part of our intention to begin speaking more freely about death and bereavement, we held death cafes expertly led by my colleague Vanessa Pritchard-Wilkes. The cafes enable people to openly share their experiences of grief and even near-death experiences. And for something that people thought might have been morbid, actually it was viewed as really, really positive. Lastly, we shared blogs across the organisation from people about their experiences of grief and bereavement and how this has affected them both personally and at work. And what we really wanted to achieve from this is for people to feel it is okay to speak about death. And sometimes people will say the wrong thing, and that's okay. It's about learning together. Next slide, please. But our work doesn't stop there. We have also enrolled a number of our locations onto the Gold Standards framework. Currently, we have 10 who are going through the process, and by mid-2023, we will have 30 registered care services, all undergoing the programme with a view to accreditation. Our target is 100% of our registered care services will be accredited with the Gold Standards framework in 4 years' time. But of course, we don't want to wait for 4 years till everyone's accredited to make sure what we're delivering to residents is the best it can possibly be. And in the summer of this year, we're releasing updated training and guidance for our workforce, not just about how to deliver really fantastic end-of-life care, but also, following on from what colleagues have said today, how to work with people emotionally and to make sure that people are feeling able to have sometimes those difficult conversations, but those conversations that we know are really important to our residents. So thank you for having me today, and that's it.
Jamie, thanks very much, and really interesting to hear about the work that you've been undertaking, and also the work that you highlighted that Vanessa does, who we know very well at from Housing 21. So that is really brilliant. So we've got about 15-20 minutes for a Q&A. We've had a few questions posted, but please, I do encourage people who are still with us. I know a few people have dropped off. Please do post your questions in the Q&A box. We've had one response already around GSF and, in fact, Gold Standard Framework. And in fact, Michael, both you and Jamie highlighted some of that in terms of what's happening in retirement villages. Before I sort of move on to some of the other questions, can I just ask on GSF, is that something that colleagues on the panel have found that extra care housing, outside of Housing 21 and Extra Care Charitable Trust and perhaps even Octavia, have taken to, or is this still very much early days? Does anybody have a particular thought on that? I suspect it's still very early days, but
if I can just say from a wider perspective, is it right to answer, Jeremy?
Yeah, please do, yeah.
I go for it? Okay, so I know the Gold Standards Framework very well because I was a facilitator and rolled it out in Swindon and supported GSF facilitators and dare I say livable care pathway facilitators, which is obviously no more around. And this has been going on, I mean, I think it's 2002, wasn't it, that Gold Standards Framework started kicking off, led by Professor Kerry Thomas. So in my experience, I think it's changed from when it started to where it is now. I think there is some uptake in some acute trusts, but they're more going in the acute sector. They're going from going good to outstanding. So for more the CQC, which the national team are supporting, and Gold Standards Frameworks, the principles are there, but I think the accreditation is variable. But someone else can contradict me that on the numbers. But it was variable, and things have kind of moved on in the community care homes, like I said, acute trust community hospitals, in my experience.
Thank you. That's really helpful. I'm trying to look at the questions as well as see if anybody's got their hands raised. So I'm just going to move the questions around on my screen. I can multitask, which some people may find surprising. Catherine, who works for an alms house, has been in touch. And actually, this is a really interesting point because not all alms houses actually operate housing with care or extra care, but they obviously support people in later life and provide a form of accommodation, retirement, a form of retirement living accommodation. And Catherine's wondering, are there any short courses or qualifications that are available which may equip people, either trustees presumably, or people who are working within the alms house sector? And I'm not aware if the Alms House Association itself has such a course, but I'm just wondering, anybody, Liz or colleagues from a training perspective, would like to come back, and perhaps Gina has a view about this as well. Liz, can I start with you?
Yes, St Christopher's has a long-standing relationship with GSF. We used it as a tool in facilitating improved end-of-life care in our local care homes, both nursing and residential. We did, over time, find that sometimes the cost was prohibitive for small homes. There were various other things, I think. I wasn't involved in the switch, but I know our care home team designed an alternative, which was called the 6 Steps. So I know that GSF is alive and well in some sectors, but I think the thing that, and I think actually we'll probably maybe ask Neil and Leanne why it's not being used at Octavia, because I think it was the deep learning that we recognised needed, for cultural change, meant that although we may consider, I don't know what the quality team will ultimately decide, and may decide to return to looking at GSF through fresh eyes. But at the time, it felt like it was, there was other, as I say, deeper learning that needed to be done first. I don't know whether Mike has got anything to add in terms of what the plans are, certainly at St Christopher's, and but we're not using it at the moment, are we, Micah?
We are not currently using Gold Standards Framework, but we are actively promoting steps to success across various sectors. And I think going back to the question around training around grief and loss and bereavement and all of that, that is part of that programme that we offer. Obviously at St Christopher's we have additional training or more bespoke and separate training around grief and loss. So if people are interested in that, we can definitely share and talk about that further. But as Liz said, in our catchment area, Steps to Success was was the preferred organisational programme for change, especially in nursing and residential homes, as the financial envelope looks quite different. It's a very similar programme with very similar standards and very similar ways of introducing change at an organisational level. But we have slightly kind of amended and improved it to also align a personal professional development program around that. So care settings don't just offer or focus on all the organizational development, they also hand in hand focus on individual and professional development, which is crucial to make both work.
That's in time. Neil, I think I see your hand up. Have you got a comment to add to that?
Oh yeah, it's with regard to the gold standard framework rather than question, I suppose. It's, I suppose from our point of view, it was our extra care schemes are relatively small, I suppose, to when compared to a retirement village, and we do have lots of people with some, as I said, very complex needs, mental health, dementia, and learning disabilities. So I think for us, I mean, the choice to go down that route of not using the gold standard framework was, I think, this program we were using talked to our care workers. You know, the fact it was co-produced with them and it was a resource suite. But I think we had this discussion, I think, prior to this session, and I think there are different pathways. You know, different. I think I spoke to Michael from Extra Care Charitable Trust. There are different ways to get to the same place, I suppose, and I think we've recognised within all these systems. I mean, the 6 steps to success, the ambitions, this resource pack. I think the principles appear to be quite similar, and they talk maybe to different audiences, and maybe people need to look at what might fit best with their organisation and the group of staff they have and where they are at that time. As Liz said, we had a bit of a journey to go on. We had limited resources available to us given our size, and wanted to make an impact, and it worked for us doing it this way. But I think there are different. So recommendation for organisations is maybe to look at all those, you know, I call them pathway, but all those resources available and come up with the best one for your organisation and your workers. Yeah.
And I see, Leanne, you've got a hand up as well. Can I just invite you to say a few words?
Yeah, I mean, just following on from that, I mean, this all came about by us wanting to have some training for our staff. And that's purely where it started. And there are different people doing different trainings out there. But we didn't want specifically to go down something that, okay, we can tick the box that everyone's got the qualification. We wanted something that was more meaningful, and we did the half day and it was brilliant. But as we said earlier, it left us wanting more, and it was wanting more for our organisation and our staff. So it isn't always a one size fits all, because it's an emotive session. You know, I mean, we had numerous tears in those sessions, and it was really how staff are going to deal with that. And yeah, for us, it worked to do it this way because we could co-produce it with our staff. But there are lots of things out there if you've only got to Google it. So, but yeah, that's how it worked for us.
Thank you. And I think Antonio earlier was sort of signposting to other things, as you say, it's a suite of resources and then it's signposts. And she's skillfully done that with Liz to highlight those. But I saw, did I see Louise's hand up? Yes, Louise. Welcome.
Yeah, I was just going to say, if anybody is starting to look at this and wants to find a starting point, a good place is the Common Core Principles for Supporting Adults at End of Life. I think that's a really good place to start, and that's freely available, as is the e-learning health online module. And I think if you look at both of those, which are free, you can then work out what you want on top of that and what kind of extras you want. So I think they're a really good place to kick off from.
Well, that's really helpful, because I think that will probably give some more information to Catherine's question as well, you know, where to look at training and resources, because I think she was probably wanting to see if there's something like the equivalent of a mental health first aider that can be developed as well. So, okay. Look, one of the questions that's just come in is really important, I think, because I think, again, Antonia and others talked about different types of diversity, and perhaps we reflected perhaps a little bit more on cultural diversity. But Bob has asked a question, which is really about looking at sort of approaches around affirmative action, people from minority groups, and he sort of draws attention to LGBT as well. And I'm just wondering whether there's anything that any of you can highlight that might be some of the learning from this programme or your work generally. So does anybody have any immediate first? Well, Michael, I think you've got your hand up.
Yeah, we had a couple of examples of residents experiencing what gets termed as disenfranchised grief, where actually, for instance, we had a couple of examples where a same-sex partner maybe wasn't accepted by the family of a resident, and actually when the resident passed away, that their partner wasn't really recognised as needed to be brought in to the grieving process, to actually come to any of the rituals, the funerals. Just actually that person is still grieving. They loved that person as much as anyone else, but they weren't included in anything. So actually, how do we support someone in that? And we probably saw that a little bit more than actually we thought we were going to see that, to be honest. And actually just recognising exactly who this person is in the resident's life, and that it's really important that the person is included in decision making around, you know, for instance, if the person is approaching end of life. But we saw it more in the after stages, where actually a person being excluded from funerals and excluding from actually being able to have an outlet for their grief. We saw that more than maybe, say, the end of life side. But yeah, it was we were actually quite surprised at how much of that we saw.
Oh, that's really interesting. Neil, do you have an additional comment on this?
Yeah, I don't have any specific examples, but I just wanted to really support the comment. I mean, we're currently developing our strategy, and the whole idea of inclusiveness really needs to run through the whole care and support planning process and into end of life planning. You know, I mean, I think we recognise that maybe, particularly with this group, maybe people aren't coming out, and we need to find ways to make sure that people can feel comfortable to come out when they're living in extra care. And that this is definitely an area going forward that we need to do more work in, I think, to ensure that we're really truly inclusive. And you can see it applied in end of life care and having those conversations, you know, who are the important people to you and why. But I think early on we need, you know, hopefully we can be having these conversations earlier, because it applies to better lives. It's not just the better endings, it's the better lives part. So
yeah, that's a really important point. I'm just wondering whether Karina or Micah or Gina have any other comments they want to make, or Jamie, have you any other comments you want to draw, either in response to Bob's question or any other questions that you've heard all the presentations?
Shall I go for it, Jeremy?
Yeah,
I didn't put my hand up. Okay. Yeah. So I think in my mind, starting off, when for any person looking, as been said before, this is a journey, and there is so much information out there that sometimes it can feel a bit overwhelming. So what I would suggest, you know, if you're starting on this journey and this is excited you to think, oh, what change can I make in my organisation or where I want to work, is the suite of resources is all there. Okay, so you've got that there to help signpost, but I would definitely go back to the 6 steps as a framework, which is based on the end of life care strategy, and that looks at the whole pathway. I know we shouldn't mention pathway, but I did. Okay, that actually it's going from point 1 of actually having that conversation to point 6, which is about that aftercare, that bereavement. So although it might seem a bit, you know, for some people a bit clunky, it's a point to start where you can start finding information off from that. So it's a simple framework. That would be my best advice. And the Gold Standards framework has some simple scenarios as well, but the end of life strategy, although it was 2008, we've got the ambitions, it's still good for some, you know, it still has a basis of good information and to get started. So I hope that's helpful, Jeremy.
No, that is. And Antonio, I see you've got your hand up, and I'll give you the final say before I hand over to Liz.
Thanks. I just wanted to say about the suite of resources. Although we've talked about this 9-week programme, and in the suite we share the the way we structured the programme and the topics and what we talked about, we really wanted it to be something that's a very flexible tool for people. So you don't have to commit to taking and delivering a 9-week programme. You can just dip in and out. So using the different themes and the different topics and looking at the different resources to just start somewhere. So if there's a particular issue that you want to look at in more depth, or start having some workplace discussions and exploration of, we hope it'll be useful for that. If you want to use it to support your use of the care certificate, we hope it will be useful for that. If you want to think about, as Octavia and St Christopher's did, developing a relationship with a local, if you're a housing provider, developing a relationship with a local hospice and thinking about whether you might want to jointly, again, co-design and co-produce some sort of educational program or development work, it might be a useful starting point. So we've deliberately wanted to share something which is adaptable, can be an inspiration and a starting point, but not saying you have to do it in one way or that there's only one way to use it.
Thank you. And, you know, on behalf of the LIN, we were very privileged to be part of this process. But Liz, over to you for the final comments before I do my final summing up.
Yeah, just to reiterate what Antonia has just said, and if any organisation today would like to know more about the project or explore the possibility of using some or all of the resources, please do make contact with any one of us, but maybe potentially me or Neil to start with. We'd very happily talk to you and share ideas. So please do that. And a final thank you I need to say to Women in Fellowship, which is a faith-based national organisation that has financially supported projects at St Christopher's that have wide impact since 1975. Their donations have funded St Christopher's contribution to the Better Lives, Better Endings project, and it wouldn't be right for me not to mention them this afternoon. And yeah, just thank you all for your very interesting contributions. We've learned a lot. Thanks very much.
Absolutely, and can I echo that, Liz? I think we have learnt a lot, and as people have been putting in the chat box, this has been a really important session to help everybody's understanding and learning. So on behalf of the HousingLIN, can I thank each and every one of you, as well as the team behind the scenes who've helped to put this on, but also the teams at St Christopher's, Octavia and partners who've helped to publish this really impressive new suite of resources. I really hope you take it and work alongside a number of the other projects and programs and resources. And I think Gina mentioned a couple more coming out later this month. So again, in the HousingLIN, we will make sure we capture that. Before I leave you, just to say you will be invited to give some feedback. I think as Sally highlighted at the outset, we do finish quite abruptly, so thanks ever so for all your contributions. If you're interested in speaking at a future HousingLIN event, our happy hours, please do let us know. We do really welcome contributions from a wide variety of sector backgrounds, as people can probably tell from our previous happy hour sessions. We've got a couple more coming up in this month, mainly focused on technology. So do watch out our emails and our website for details of our next 2 happy hours next week and the week after. And if you want to engage with the LIN, come and talk to us. Visit our consultancy and other pages on our website. We're very open to having further conversations and sharing your practice as well. So please do liaise and keep in touch with us and keep networking with the HousingLIN. So on behalf of everybody, can I do thank, I'm going to say everybody by name, Antonia, Liz, Gina, Maker, Leanne, Neil, Jamie, Michael, Karina, Louise. I think I've covered everybody. I've lost you all, and the team behind, and Michael, if I've not said to you as well, thank you ever so for joining us today. It's been a really impressive session. I wish you all a really happy evening. Bye for now.